Hey everybody, good morning. Sorry, it was an
Good
account
morning.
issue. Good morning, sorry about that. It was an account issue. I didn't have the correct Zoom account, so I couldn't let people in until a little bit later, but by all means. Welcome everyone back to Rounds. We've had a couple of weeks off just with our retreat and with Anouk last week, so welcome back everybody. So very happy this morning to have Dr. Morantz to start us off. And I'm going to just unshare my screen and Dr. Morantz, you can go right ahead.
Hi, good morning, everybody. Yes, you'd think I'd figure this out by now. I'm just gonna figure out how to start to, I know to share my screen, but get my presentation up at the same time, okay?
Yeah.
So, hang on. There we go. Okay, so I'm not sure if I've met many of you. I'm a pediatrician at the Metaphyseal Children's Hospital, and I work in our child protection team. So thanks very much for the invitation. I apologize again. There was a previous session where I was supposed to present, and anyways, there was a big confusion on my part. But I'm here now, and I'm going to talk to you guys about when to be concerned about child protection issues related to skin injuries and fractures. This is part of a larger talk where I could also talk about other manifestations of child abuse, but I think we'll, for the sake of time, we'll focus really on the two most common manifestations and when you're most likely to see. But if you have any questions about anything, just let me know, and you can either put it in the chat, which I can't see, or just speak up. So good morning. Okay, this presentation was adopted from a presentation that Dr. Kimoff and I gave during Practical Problems, but it's been updated a little bit since then, and I have no commercial interests. So we're going to very briefly go over the Youth Protection Act, which I'm sure you're all familiar with. We'll go through some history and physical exam tips. We'll talk about bruising, we'll talk about fractures, we'll talk about the basic workup that we do. And then if we have time, which I don't think we will, we'll talk about traumatic head injury due to child maltreatment, burns, and intra-abdominal trauma. So just very briefly, I wanted to go through the Youth Protection Act because it's what lays down the foundation for our duty and obligation to signal cases of suspected child maltreatment. So it came into force in 1979, last amended in 2017, and it basically aims to ensure the rights of children and adolescents who might be in danger. And it's what gives the powers to the DPJ for French-speaking families and Batcha for English and Jewish families, the right to basically put into child protection measures such as, putting a child in foster care or mandating parenting programs, etc. So while you're at work as a healthcare professional, you have a duty and obligation to report all the situations covered under the Youth Protection Act, whereas in the rest of your life, or most citizens, really only have an obligation to report any suspected sexual or physical abuse cases, and then have it's suggested that they report other cases, other types of child maltreatment as well, but it's not a legal obligation. So very briefly, so there's different categories of child maltreatment. In Quebec, psychological ill treatment is one of the categories, and it's basically when a parent or caregiver is repeatedly subjecting a child to a behavior that is denigrating, exploiting, threatening, or isolating. But the majority of this category is also, like most reports, are related to exposure to conjugal violence, because this, in Quebec, conjugal violence falls under psychological ill treatment, and that's in the majority of cases when someone's reporting for physical ill treatment, it's related to exposure to conjugal violence. Then there's neglect, which is basically not meeting the basic needs of the child, either with respect to feeding, clothing, medical care, schooling. And obviously there's a fine line between neglect and poverty in some occasions. So that obviously needs to be taken into consideration as well. Abandonment is basically leaving a child. Then in Quebec, which is unlike other provinces, we actually have our youth protection has another mandate as well, which is to take care of children where they're behaving in a repeated or serious way that interferes with their own personal well-being and the well-being of those around us. So for example, a child with serious behavioral issues, a parent or a school can make a signalement, and sometimes these children will be put into like a group home, for example. And then obviously sexual abuse is the other main category. So it's basically subjecting a child to gestures of a sexual nature with or without actual physical contact. And DPG or BACHA will get involved if the caregiver is if there's either a caregiver that's offending, or if their parents or caregivers are not protecting the child from the offender. This is obviously also it could be criminal charges as well. And then there's physical abuse, which is what we're talking about today, which is when there's a child that's a victim of injury or at strong risk of injury at the hands of a caregiver or another adult. So if you look at this signalement, this is the most recent data that I could find. Physical abuse is about a quarter of the cases that are retained. So when you report to DPG or BACHA, some cases will be just, upfront, they won't get involved. Other cases they'll investigate and then close, but some cases will be retained, and those are the ones where they, might put child protection measures in place. So of those retained, quarter were physical abuse, about 20% are neglect, and then the third is psychological maltreatment, which, as I said, is mostly exposure to conjugal violence. In the first wave of the pandemic, there was a serious concern that a whole bunch of cases of child maltreatment were being missed because children weren't in that protective network of schools or with other professionals that could keep an eye on them. And there was actually a big reduction in cases reported to DPG in the first wave of the pandemic. And we know that a lot of kids were sort of trapped in their homes with their abusers. So in the first wave, there's a 20% reduction in signalement. But interestingly, in some studies looking at, as you were working in the emerge, I'm sure you know that during the first wave, there was actually much less patients in general coming into the emergency room. Everybody was scared and just staying at home, and their viral illnesses, or I guess, were just getting better on their own, or there were less viral illnesses. But the percentage of children coming into the emerge with child maltreatment or physical abuse was actually higher as a proportion, which is unsurprising given, the added stress of the pandemic. Okay, so I just want to see if there's a way for me to see the chat. I'm scared. Could someone moderate the chat for me?
I think another thing that you can do is if you go so you're sharing your screen, and then if you go to the top of your screen, there's like a green bar.
Okay.
And then just kind of leave your mouse on that, and then something should drop down, and then you'll see chats kind of on the right side of that drop down bar, which
I got
maybe
it. Thank you very much.
If that's easier for you, we can also monitor.
No, I see it now. It's all good. Thanks. I'm used to Teams, which I hate even more. But anyways, okay. So right. So this is we're just kind of talking about some red flags now on history and physical exam for child maltreatment. Oh, now I can't. All right. Okay. So this is a made up case, and I'd like you guys to participate in the chat if that's okay. So it's a 6-week baby boy who's brought into the emergency room because he was first noticed 2 days ago that he wasn't moving his left leg very much, and he seemed to be crying when it was moved. Mom says she thinks he might have fallen off a change table 3 nights ago, and on exam he's got a swollen and tender left lower leg. And this is an X-ray. There's a fracture in his tibia. So this is just, like I said, a made up case. So what are some of the red flags for physical abuse in this case? Please feel free to write something in the chat. Yeah, perfect. So we have 2 days ago, it was a delayed presentation. He's 6 weeks old. So, is it even realistic that he could fall off the change table in terms of his physical abilities? Where the fracture is, that's correct. Falling from a change table, the tibia is not the most common place that you would get a fracture. The type of pattern of the fracture doesn't fit with necessarily like a simple fall. And yeah, and a fracture in a baby that's not yet mobile. Yeah, so those are all, this is like, as I said, a made up case just to highlight some of those red flags. So in this case, oops. So yes, there's a delay in presentation. Also in this case, the mom's like, well, I think he might have fallen off the change table. So it's a vague explanation, right? You know, usually with a baby, it's binary, like either they're on the change table or they're on the floor. And you really should know where your baby is at all times, because as we've discussed, they're not mobile at this age. Obviously, if the history changes, if the explanation is inconsistent with the age of the child, the pattern or the severity of the injury, so you need to know what kind of mechanisms of injury cause which kind of fractures. If the explanation is inconsistent with the child's physical or developmental capabilities, or if different witnesses provide different explanations. I will say because, so yes, it's very rare that a 6-week-old can roll, but the youngest baby that I've assessed that was, you know, had basically a skull fracture from a fall from like a reported roll off the counter was an 8-day-old. And I was like, there's no way. And then I went to the emergency room and I put the baby on the stomach and I watched him roll right in front of me. So when you look in the literature, there actually are some like babies that can actually roll from a really young age, but never mind, like regardless, obviously it's a red flag, right? Because not that many 6-week-olds or 8 days old or babies can roll. So when you suspect that physical abuse is a possibility with the patient that you're seeing in front of you in the emergency room, you want to make sure that you get a clear description of the mechanism of injury, and try and, this is really important for all of you because it's going to be my problem later on. Please document extremely clearly what is told to you of the mechanism of injury, because if later there's a change in the history, that's really important information for me. So write clearly in good handwriting, exactly, almost verbatim, if possible, what's told to you about the mechanism of injury. And, you know, it's sort of debatable how much detail you want to go into, but I usually ask questions about like how high, what surface did the child land on, who was in the home when it happened, who saw it happen, what position did the child land in, you know, what were they wearing, if you know, child's got bruises, for example. So you really want to try and get as many details as possible, because as I said, if they change over time, that's concerning. As I mentioned, you want to document clearly. You want to avoid leading questions like suggesting a possible mechanism of injury. So, you know, we're not investigators, but I will usually ask an older child if they have an injury, at least well, once usually, if they can tell me how this injury happened. You want to avoid repetitively interviewing, especially children, because their stories can change, just because they can be easily persuaded. You want to avoid an accusatory tone. Like the person who's bringing in the child might genuinely not know what happened because they might not be the potentially offending caregiver. And it's not our job. As I said, we're not investigators. And also very quickly, you want to know who are the people taking care of the children if there's other children in the home. Because if there's a case of suspected child maltreatment in let's say a young infant, and we find out that there's another young infant in the home, let's say there's a twin or another young child, we're going to be signaling DYP much earlier in the process than if we find out it's an only child that's getting admitted for a workup and we have some time that we can wait because we know that that child's in a protected environment. So very quickly, you want to find out what other kids are in the home. So in terms of physical exam, you want to do like a full head to toe exam, including the places that we often forget to look. So inside the mouth, behind the ears, take the diaper off, look at the genitalia, look at the bum. You want to document or look for any kind of suspicious skin injuries. We'll talk a little bit more about that after. If you see evidence of neglect, so you know, if the child is really malnourished, if there's signs of like an untreated infection or severe diaper rash, if there's poor hygiene. Granted, like I remember one of my first child protection consultations, I documented that a child had like a 4-month-old had long fingernails, and I had a baby and realized it's actually like really hard to cut their fingernails. So, you know, I think we have to try and interpret the injuries more objectively, but you know, you could document if there's other signs as well. And then part of the role as well as physicians when there's a child with an injury that's suspicious for child abuse is to make sure that there's not an underlying medical or genetic condition that could be causing it. So we want to look for other signs of metabolic or genetic disorders that could present with either bruising or fractures or, in the cases of subdural hemorrhages of bleeding. And yeah, so we usually draw on a body diagram. I think there should be some available in the emergency room. And there's also a camera, which is located in the opioid closet that the nurses have access to. So if you're seeing a case in the emergency room where there's some physical findings, specifically like bruises that might fade or change with time before they can be assessed, we do recommend, you can always call us, but we do recommend to take pictures with a consent obtained by the caregiver or by DYP. So this is an example of a body diagram. So you want to document clearly all these skin injuries that you're seeing in terms of like their size, their shape, their color, as detailed as possible. And then, a picture's worth 1,000 words. So ideally you would take a picture as well. Okay, once again in the chat, I'm just wondering if any of you guys can tell me what the injuries are that you're seeing in these pictures.
So there is subconjunctival hemorrhage. Yeah.
Yeah. So in the bottom picture, there's a subconjunctival hemorrhage, which in this case happens to be associated with like periorbital bruising. So it's obviously suggestive of an impact or trauma. But sometimes you'll see just isolated subconjunctival hemorrhages, and there is a differential to them. So it can happen with increased pressure. So for example, forceful coughing or vomiting or crying, you can get or birth related, you can get a subconjunctival hemorrhage. But it is also possible that it happens from trauma. So it should be, if you see it, obviously if in a kid with like gastro or something, I wouldn't necessarily be all that concerned, but it is considered a sentinel injury, so an injury that could be indicative of abuse. So just to keep that in mind. And then yes, you're right. The pictures above are torn frenulum, which is something that we always look for as well, because it's, especially in an infant, it's suggestive of like forceful penetration into the mouth, usually like a bottle. If parents are getting frustrated with like a crying baby, they'll sometimes shove a bottle into the baby's mouth and tear the frenulum. And there's 3 of them in the mouth. There's one below the tongue, and then there's one below, the upper lip and the bottom lip, and the one that's most often torn is the one under the tongue. However, some babies also have that clip, so you want to get a history of whether or not there was actually a clipping of that. Okay, so we'll talk about skin injuries. We'll just go through a case together. So this is the child in question. It's a 2-year-old boy who previously was living with his mother, went to visit the father for one night, comes back the next day. Dad says he had fallen out of bed. Mom sees him and he's got, significant bruising periorbitally, bilateral. Prior to that, he'd never had any concerning bruising other than just really like regular bruises in the mom's care. And he was otherwise well, except for some speech delay and recurrent otitis. So then you examine him a little further. So you see that he's got bilateral periorbital bruising. He's got bruising on the forehead extending down into in the temple bilaterally, bruising on his shoulder, bruising on the posterior surface of his thighs, bruising over his back and his right flank. So his vitals are stable. These numerous bruises. He's got a swollen upper lip. He's got a torn frenulum. Right. So this is what you're seeing. And just in the chat, you could say how concerned you would be for inflicted injury in this case so far. Yeah. So very, yeah. So obviously there's a differential to this. It's a child that's got, acute bruising. So you'd want to rule out some kind of, ITP or leukemia. But yeah, this presentation of like a acute onset of multiple bruises, even in a mobile child, there's with only a history of a fall from a bed, it would be, I would also be very concerned. Yeah, and he has a frenulum limb tear as well, right? So when you're considering children with bruising in the context of suspected child maltreatment, there's this wonderful Canadian Pediatric Society article that I definitely would draw your attention to. And so it goes through some of the red flags for inflicted injury. So as we mentioned before, any bruising in a baby who's not yet cruising, so non-mobile babies generally don't generate enough force to cause bruising on their bodies. Any bruising in a child over the ears, the neck, the feet, the buttocks, or the torso, because those are either generally protected areas or areas that are like fleshy, like the bum, which are, there's a lot of cushion, so it doesn't bruise as easily, and often in infants protected by a diaper. Any bruises that aren't in the front of the body or overlying bone, those are harder places to bruise. And if you think about it, we're generally moving forward in space, not backwards. So it's true. I mean, like all of us have probably backed into a table and gotten a bruise on the back of our leg, but it's more rare to have bruising on the back, on the posterior surface of the body. Bruises that are unusually large or numerous. That's obviously sort of like a subjective. It depends on the child and how rambunctious they are. Any bruising that's pattern. Pattern injury is suggestive of impact with an object. So it's rare that you can get that in an accidental injury, although it does happen. And any bruise that doesn't fit the mechanism that's being described. So, the common places that kids get bruises, like the forehead, the shins, the back, lower back, especially over the spinous processes. Those are very common areas for children that are mobile to have bruising. And then more rare places, as I mentioned, the posterior surface of the area, and then in the, we call it the 10 area, the torso, the ears, the neck. So this 2-year-old who had the bruises while visiting the father, what would you do in terms of workup?
An X-ray.
Yeah. So by the book, a child over the age of 2 doesn't necessarily need like skeletal survey or head imaging if they're neurologically intact, but they definitely need a workup for a bleeding disorder. However, in this case, because the child had such extensive bruising, including over the head area, he did end up getting like a pretty full workup. And so everything for him on this list was done. So here is so sometimes I'll get calls from you guys about about a child with suspicious bruising, and I'll usually ask you to do this blood work before I come in and assess the child. Obviously won't get all the results back, but this is to get the ball rolling. And this is the recommendations for what should be done as first line lab testing for any kind of bruising and suspected maltreatment. And we do this in cases even when we're pretty convinced that the child abuse has occurred, just to sort of be able to prove sometimes later in court that there is no bleeding disorder that explains the bruising. So I recommend that you take a look at the CPS statement. And it's basically what you would expect, like CBC, coags, von Willebrand studies, factor 8, factor 9, liver function tests and renal function tests, looking for a platelet dysfunction. And if there's any history of a family history of bleeding disorder, or this child, has had previous concerning bruising in, other care settings, then you might want to go, or if like bruising is the only manifestation concerning for child abuse, then we often will get hematology involved and do some second line testing as well. So this is from the AEP statement, what's recommended, and actually the Canadian Pediatric Society recommends a little bit of a broader heme workup than is recommended in the American literature. And then any child less than 2 years, when they have suspicious bruising, should also have a skeletal survey. And then for infants, they should also have head imaging. So the whether or not an infant will get head imaging really depends on how old they are and how much you can rely on their neurological exam. So in this case, he had a workup, he had normal CBC, normal coags, normal, actually, I didn't mention this, but, we have to think about these as like potential trauma patients. So we also do screening for intra-abdominal injury. So an AST, ALT, amylase lipase, and a urinalysis. In his case, all of this was normal. He had a CT, which just showed a biparietal scalp swelling, but no other injuries. His skeletal survey was normal, and his eye exam was normal. So essentially DYP obviously was signaled. they got the police involved because we don't call the police directly. It's called the entente multisectorielle between the police and DYP, where DYP will call police if there's concern for a case where there could be criminal charges. And so this child ended up going home with the mother. If you look at the incidence of different bleeding disorders worldwide, they're pretty rare. The most common one is von Willebrand's disease. And what you need to keep in mind is that even a child with a bleeding disorder could have been abused. But that obviously we need to look for bleeding disorders, but they are quite rare. So this is, sort of like typical locations, as I mentioned, for accidental bruising, the forehead, the shins. This wouldn't concern me at all in a mobile child. And there's actually like good studies that have looked at children on like well baby visits to see how many of them have bruising at different ages. And so there's good evidence that before you start moving, you really very, very rarely will bruise. And as I mentioned before, that 10-4 rule. So any bruising on the torso, the ears, the neck, or anywhere if the child is less than, less than 4 months, but usually it's before they're like cruising. So we'll just go in the chat and let me just check the time. Okay. If you could just write a few things, potentially what you see, if there's any, what from these pictures would concern you for child abuse, if anything. Yeah. So people have commented that in the middle picture, you can see what looks like pattern bruising on the face that's suggestive of a handprint. So yeah. And then we have bruising on the torso in this young infant. And multiple bruises at that. And then this one, you guys mentioned, oh, I don't see someone mentioned burn. I don't know which one they're talking about, but these are all bruises actually. Although sometimes it's hard to see just from a picture. Yes, and then bruising over the buttocks. So like that fleshy part that's usually, oh, this one you're wondering about cigarette burns. I mean, actually these are bruises, but because they're very circular, I could see why you might suspect that. And then, right, so bruising over the buttocks and that fleshy area that's usually protected by a diaper would be concerning as well. What about these guys? Yeah, so bruising behind the ear. So it can rarely happen from an accident. For example, a child like tobogganing, for example, that smacks their head against the side of the toboggan or on a tree, you could see a like accidental ear bruising, but it is a very rare location for bruising from an accident. And then in this picture, I don't know if you can see my pointer, but can you? You can just know. Anyway, there's bruising here over the torso.
Oh yes, we can.
Oh yeah, okay, perfect. So here, obviously, there's bruising in an infant over that torso area. Oops. What about here? Oops. Sorry. So, right. So these are two different people, but yeah, so we have here we have bruising on the cheeks in an infant. And the way the pattern of the bruising goes, or it's somewhat suggestive of like a grab mark here, but either way, it's just sort of bruising on the face of a young child. And in this picture, you see sort of pattern bruising, which is suggestive of a looped object. So in this case, I think it was an electrical cord. And yes, this child should be old enough to give a disclosure. So, okay, pop quiz. I don't know if you guys know the answer, but how old is a green bruise? Okay, right. So we're getting some 1 to 5 days old, and we're getting a none. So the truth is, we have done tons of studies about bruising, and we really just can't date bruises at all. We're just terrible at it. Both humans and computers actually are bad, really bad at dating bruises. So the bottom line, after all of these studies that I've done, that have been done are that any colors can be observed in any bruise at any time. And there's no scientific basis to dating bruises. So basically all my reports say that I'm not able to date a bruise based on its appearance. We know that children can sustain like multiple bruises at the same time and that they will heal with different colors at different times. There's some suggestion that if there's yellow or green in the bruise, it's been there for at least 18 to 24 hours, but even that I wouldn't comment on. I would basically just say you can't date bruises based on an appearance. Sometimes I'll say, you know, if there's a picture of a child like the day before where there are no bruises, and then the day after there's bruises, I could say that, you know, based on a review of the photographs, it doesn't seem that there were bruises like on a certain date, but otherwise I really just say I can't date bruises. Okay. Are there any questions about bruises before we move on to fractures?
I was just wondering, so you can't date the bruises, but let's say on the patient, they're just a variety of different colors. Would that, so you can't date them, but okay.
No, because we know that on different locations in the body, even if they're sustained at the same time, they can heal with different colors. And there's actually like studies where they put suction cups on people and induce bruises and then look at how they evolve over time. And we know that you just really can't date them based on the color or their appearance.
Okay, yeah, thanks.
Okay, so we'll shift gears. We'll talk about fractures. So this is a real case. So this is a 6-week-old baby boy that I saw over Christmas, obviously. So it's great. So he had presented similar to the other case I'd presented at the beginning. So he had come to the emergency room with 3 days of irritability, swelling and decreased movement of the left lower leg. He had no history of fever or trauma, was feeding well, uncomplicated pregnancy and delivery, and on exam had a tender, swollen, and warm left calf. So this is the X-ray that was taken. Can anyone see? You guys are all emerged, so you should hopefully be able to see the injury. Does anyone know what kind of fracture that is? So someone's asking Salter-Harris 4. So this is a 6-week-old. So we don't usually use the Salter-Harris classification in a 6-week-old. I'm trying to remember what Salter-Harris 4 is because it's not something that I often see in my child abuse work. That's usually older kids. Yeah, so I'll show you guys the fracture. It's right here. Now that I'm pointing it out, does anyone know what that's called? So in this view, it would be called a bucket handle fracture. So you can see how it kind of looks like essentially a bucket handle. And in this view, oops, sorry, the lateral view, here you can see that there's like a chip here and actually here as well in the fibula. So this is, in this view, it's the same fracture, but in this view, we call it, you would describe it as a corner fracture. And do you guys know corner fracture, bucket handle fracture, what kind of like fractures those, like the other word for those fractures that might be more? So these are descriptive terms like corner or bucket handle, but these are considered classic metaphyseal lesions. So I'll talk about that in a moment. So anyways, this child has a fracture through the tibia and through the fibula without any history of trauma. So what would you like to do? As I kind of just put it all out there, but right, so you want to complete your physical exam. You want to screen for intra-abdominal injury. You want to do a workup for bone diseases because he's got, he's a young baby with fractures. I would imagine you would probably, he's got unexplained fractures. You'd want to do like a skeletal survey, make sure there's no other fractures. You do a brain imaging and eye exam, and then probably a social work consult, probably admit. And then it's the first baby, so you have a little bit of luxury of time, but unless there's something obvious on the workup for bone disorders, you're probably going to be calling youth protection pretty quickly. Right. So as I mentioned before, skeletal surveys are part of our workup for any child with suspicious injuries under the age of 2. So that would include like bruises in a non-ambulatory infant, oral injuries such as a torn frenulum, in a non-ambulatory infant, infants with well, unexplained death, but that's usually the coroner that'll do it. And then, if there's any signs of intracranial injury or hemorrhage in a young infant without a clear explanation, or there's concern for inflicted injury. And then we also do it for contacts, like household contacts, like siblings, young siblings under the age of 2, when there's a child that's been found to have suspicious injuries or where we suspect child abuse. We'll also do skeletal surveys for their siblings. So we do the skeletal survey. In this case, it's a 6-week-old with the tibia and fibula fractures, and we see yeah.
Sorry, I write like a really, I'm doing this from my phone, so it's bad. So mainly, do you trust these parents when they tell you, this is how many kids I have, or the DPG does come to check that?
Ooh, that's a really good question. I mean, I've never sort of questioned whether the parent would be lying to me about how many kids they have. That's a really good point, though. I guess I mean, yeah, but yeah, I mean, even in the case where there's like an only child, you are going to call DYP. Just do you call them that night or do you wait till the next day because they're getting admitted anyways? I don't think I've ever been lied to by a parent about how many kids they have. That's a really good question. I'm not I'm not very suspicious by nature, but yeah. So I usually like rely on what they tell me. Sometimes you have to ask specifically, are there other kids living in the home? Because let's say a mom is bringing in a kid. There might be like it might be a stepson, for example, like her partner's child that's in the home that if you ask do you have other kids, she might say no. So you really have to ask like clearly, are there other children living in this home? But yeah, like I'm not saying that you're going to wait a super long time before involving DYP. It's just like, are you going to call them right away or are you going to wait till you get some blood tests back? Or like do your skeletal survey with a little bit more information. So, but yeah, I've never, I'm going to question that. I've always sort of trusted what parents told me. Maybe that was wrong.
I didn't want to undo
usually
your
parents,
practice.
yeah, usually parents aren't like super sophisticated criminals that are going to like lie to you about that kind of stuff, that at least not that I've encountered. But that's a good point. I will definitely be a little bit more careful. Right. So in this case, we do a skeletal survey and we find these other findings. So this is the acromion, which is the extension forward of the scapula. You can see there's bilateral findings in the acromions, which actually the radiologist at the time of doing this skeletal survey wasn't sure, because it's so symmetrical, if it was a fracture or if it was some kind of congenital variant, because you actually can get congenital variants in the acromion. So we actually repeated the skeletal survey, which is something that we do quite routinely. So the reason you repeat a skeletal survey is to look for fractures that you might have missed on the initial skeletal survey, because some fractures become more obvious as they're healing. And also because if you have findings on the first one, you want to sort of follow up and see how they're healing. It might give you some better idea about the dating and confirm that they're fractures. And see like how the healing is going, because sometimes children with like osteogenesis imperfecta, for example, will have abnormal healing of fractures. And so it can actually provide a lot of information. And as I mentioned, we'll sometimes even do it in cases where the initial skeletal survey is normal, if we're really concerned about an inflicted injury, because like I said, some fractures you'll see more like as they heal. Right, so we repeat one usually in 10 to 14 days. So in this case, right. Where's my, all right. Okay, so then we repeated this little survey in this case, and you can see now that it's clearly not just a congenital variant, right? Because now there's like sclerosis and change. So that basically confirmed the findings that this child had a, I'm sorry, there was a question about repeating a skeletal survey. I hope I answered it, but if I didn't, just let me know. Right, so in this case, we repeated it. We confirmed that these are actually fractures. Okay. Right. Okay. So how concerned would you be in this case for inflicted injury? So here we have a 6-week-old baby with tibia and fibula fracture and bilateral acromion process fractures. Very. Yes, you're still very concerned. Good. I mean, I would be too. This is a scale. It's available in a publication by Lindbergh. The way that you phrase or frame your concern varies by center and by physician. Some people talk about language of like suspicious, very suspicious, not suspicious. Some people talk about probable or definite. I mean, it's actually rare that you're definite, but or possible. Some people will talk about like likelihoods, like most likely, least likely. And I think it really depends on like how you feel most comfortable and where you were trained. So I was trained at sick kids where they use the suspicious, very suspicious language. So I tend to use that. I also use concerning sometimes, depending on yeah, it really depends on how concerned I am. It's very rare that we'll say definite inflicted injury, although I've had cases where you know, there's been a clear disclosure with an injury that's in keeping with the disclosure. Well, I'll say, you know, this is considered child abuse. But yeah, it does happen. So in terms of inflicted injury, fractures are the second most common manifestation of child abuse. So the most common are actually bruises, but fractures are number 2. And we know that abuse is actually 20 times more likely than osteogenesis imperfecta and 100 times more likely than metabolic bone disease when you're suspecting child maltreatment. So the age group in which we see the most abusive fractures are the young infants, where children are non-mobile, so it's hard for them to generate enough force to cause a fracture. The exception to that is, you know, simple falls, which do occur once babies start rolling. And as we discussed earlier, you know, if a baby does have a simple fall, the most common location that it'll have a fracture is in a skull, because babies are top heavy. Sometimes you'll see a fracture that it can be clinically silent, that you'll do, let's say, an x-ray for a broncholytic, and then you'll see a rib fracture. And then the fractures that are actually they can be quite specific for child abuse, such as rib fractures and classic metaphyseal lesions, can actually be quite silent clinically. So you can examine the kid, have no idea, and do a little survey and then find a whole bunch of CMLs. It's happened to me. Okay, so which of the following factors would be for you most suspicious for physical abuse? I might have already given the answer to this.
Spiral tibial fracture.
So it really depends on the infant's age, how worried you'd be about a spiral tibia fracture, because in a child that's mobile, a spiral tibia fracture would be considered a toddler's fracture, which is a fracture that you can get, as you know, from like falling or tripping over your own foot. And so a lot of the times in a toddler's fracture, you won't even have a history of trauma because the parents might not have noticed that, like, just trip and cause the fracture. But yeah, so in this list, I guess I really should have said the age of the child, but really for an infant, it would be a rib fracture that I would be most worried about, because as we mentioned, linear skull fractures can occur from a simple fall. Spiral tibia fractures, especially if they're mobile, can occur just from a simple, like, falling over their own feet. Humerus fracture can also happen from a fall, but a rib fracture is a very rare accidental injury, and it has to do with the mechanism involved, which is usually a compression of the rib cage, which can happen in things like a motor vehicle accident or like a child where, you know, someone's fallen on top of them. But because of the mechanism involved of a compression, it is a concerning injury for child abuse, because one of the ways that it'll occur is if a parent is, you know, forcefully squeezing the rib cage. So in terms of red flags for abusive fractures, a child with multiple fractures would obviously be concerning. Fractures in various stages of healing. And like bruising, we can sometimes do some dating of fractures, some radiographic dating, but it is like fraught with controversy. Although there is some predictability to the way that fractures will heal. Any fracture in a child who's not yet walking or crawling. Any fracture could be from abuse, but some are more like specific or concerning. So as I mentioned, the metaphyseal corner or bucket handle fractures, also called classic metaphyseal lesions, and then fractures of the ribs, of the spine, complex skull fractures with some exceptions, and the scapula. And then obviously if there is a child that has fractures in conjunction with other injuries that are suspicious for abuse. So intracranial bleeding or like bruising or other kinds of injuries. So this is 2 cases of a child with a spiral femur fracture. One's a 6-month-old, no history of trauma. She's able to sit and roll. One is a 3-year-old who was previously well, also no history of trauma. So in this case, how concerning would you be for these 2 children for child abuse?
It seemed very repetitive.
Okay. Yeah, so I agree, like both kids that I would have some concern. But in this case, age and level of mobility really does matter because a 6-month-old who's non-mobile, it's really hard for them to sustain a fracture like this. But kind of like spiral tibia fractures, which are toddler fractures, in the last few years, there's been pretty much like a shift in how we think about them. And it's now well understood and agreed upon that a mobile 3-year-old mobile child can actually sustain a femur fracture, like a spiral femur fracture from like a fall over their own feet or like a trip. So it's definitely more rare than the toddler fracture, like the spiral tibia fracture. And so it does definitely merit some like investigation, but I'm willing to accept it much more readily than I would be a fracture, a spiral femur fracture in a non-mobile infant. So in this case, age matters. In the first case, so these are 2 real cases, the 6-month-old, the child got placed into foster care, and the 3-year-old boy, this had happened at daycare, where, he was playing in a room, picking up toys. The teacher was talking to someone in the hallway. She turned back, saw him sitting on the ground crying, and, we ended up determining that it was probably an accident. He probably like tripped over his own feet while he was picking up toys. There's a wonderful CPS statement written in part by Dr. Akimov, so I highly recommend you take a look at it. It goes through some of the history and clinical findings that are suspicious for inflicted fractures. I think we talked about most of them already, but this is a great article. And I'll show you after. It also goes through what workup we normally do looking for bone diseases. Okay, sorry. In an adult, a femur fracture requires very significant injury. Yeah, so in a child, it's considered, it is different. Like I said, it's not that common that you'll get a femur fracture from a kid tripping over their own feet, but it actually can happen. There's some good evidence and publications to support that. Kind of like a spiral tibia fracture can occur just from a child tripping over its own feet. I would definitely, if it's unwitnessed, or there's not multiple witnesses, or there's any other concerns, I would definitely, consider calling child protection for us to do a full evaluation. But it is considered possible for a child to accidentally cause a femur fracture with a fall if they're mobile. And we often will do a workup for bone health in these cases as well, but it is possible. Like I said, though, obviously I would still maintain an index of suspicion, and especially if it wasn't like witnessed by multiple people. But yeah, it is. I'm willing to accept that it's a possibility. Okay, so these are rib fractures. As you can see, these are in a stage of healing. So when there's callus formation, they're more easily visible. In the acute phase, they can literally just be like a tiny little line that's hard to see, as you know. Sorry. They can be subtle clinically. They can be missed on the x-rays in the acute phase. They can be found incidentally on a chest x-ray done for another reason. They're rare in accidental or birth trauma. You can sometimes see them in motor vehicle accidents or in children with bone diseases, and it's usually compression of the rib cage, as I mentioned. So the metaphyseal corner fracture or bucket handle fracture or classic metaphyseal lesion is another concerning fracture. It can be very subtle clinically as well as radiographically. And you sometimes see it better in the stages of healing, or sometimes it actually heals without that much sclerosis or other signs of healing. And the reason that they're so concerning for child abuse is the usual mechanism is one of like traction or torsion. So basically like a caregiver tugging or twisting an infant's limb, or an infant being held around the middle and shaken will have they can have their little limbs flailing, and they can generate some corner fractures that way. So because of that mechanism of injury, they're quite concerning for child abuse. There's some, case reports of rare accidental causes, such as, like, for example, like if a baby was falling off a change table and a parent like grabbed them by the leg and pulled them up, you could see how that might generate like 1 or 2 corner fractures in that one limb. But it's very rare from accidental injury. In the absence of a bone disease. It could also happen there's some case reports of it occurring at birth. So for example, if there was like a baby that was stuck and someone like tugged on a limb to try and get the baby out, that could be an explanation for a CML. But in the absence of those like rare cases, they're considered highly concerning for child abuse, although it can also occur in some bone diseases. So we need to give that consideration as well. So there's a broad differential for skeletal injuries. Trauma is the most common cause of skeletal injuries, but trauma can be either birth-related, accidental, or inflicted. Then there's the genetic bone disorders such as osteogenesis imperfecta, which, as I mentioned, are 20 times less common in suspicious fractures than actual abuse. Although, if fractures are the only manifestation making me concerned for abuse, I will still recommend that genetics see the child and have a workup. So most of them will end up getting tested for OI, but you still need to make a child, like it takes like, I don't know, 2 to 3 months to get the results. So you still need to put into place like a child protection decision in the meantime, unless obviously there's other features or a family history that are making you strongly suspect OI. Then there's some more rare disorders like Menkes, which is a disorder of copper metabolism, which is why copper is on the list of things we need to test for. There's infantile cortical hyperostosis, which is Caffey's disease, where children get basically like a double layer of bone, most often in their mandibles. It's a pretty rare condition. They can have like swollen cheeks. I saw it once. Then there's like conditions affecting like metabolic bone health, so vitamin D deficiency, osteopenia of prematurity, some medications that can affect bone health, which are all in the differential, and we do testing for it, and you might get some historical information in support of that. So for example, of an extremely premature baby or a baby that's on certain medications that can affect bone health. So it needs to be taken into consideration. Obviously things like osteo, like infectious causes are also possible, although that's usually clinically apparent. Changes in the metaphyses can sometimes be related to congenital syphilis, so we often screen for that as well. And then, sorry, I'm just going to check. Oh yeah, leukemia is obviously on the differential, but those are usually have other symptoms as well to suggest, or like there'll be like some kind of progression in the disease, and it'll become pretty apparent usually. So the workup that's recommended for bone diseases, also from that CPS statement, is CBC, ALT, creatinine, bone health markers, so calcium, magnesium, phosphate, alk-phos, vitamin D, PTH, copper, ceruloplasmin, screening for Menkes, urine calcium to creatinine ratio. We also screen for intra-abdominal injury. So as I mentioned before, AST, ALT, amylase, lipase, and a urinalysis. If there's changes in the metaphyses, you probably want to do a VDRL, especially if it's an infant, to look for congenital syphilis. I usually consult genetics, and sometimes they recommend a bone densitometry as well, which can provide some information. And then, as I mentioned, I highly recommend you take a look at this excellent CPS statement that Laurel was one of the authors on. And I think that's it for fractures. I think there's like 4 minutes left, but I think we should probably stop there because like the other types of injuries are like a whole other talk. So do you guys have any questions about anything?
Actually, I do. I have 2 questions for you. First,
Sure.
thank you so much for that great talk. We don't hear enough about it. When there's a case of suspected repeated trauma, so let's say that a child was seen a year and a half ago and then comes in and it was ruled out that DPG was implicated, and they said, no, we don't think there's abuse, and he comes back and there's another suspected injury, would you repeat all these bone workup? And like you would screen for other injury, but like in terms of labs and phosphate and all in all, would you?
That's a really good question. I mean, I think let's say let's say the baby or the child already had testing for OI and it was negative, like that I definitely wouldn't repeat, because that obviously wasn't going to change with time. But I probably would repeat the markers for bone health, just because, I mean, diseases can evolve over time, and I wouldn't want to like overcall like a suspicion. And also because, I mean, it's a, you know, it's a blood and a urine test. It's not like an invasive kind of test. I've had like some unfortunate cases of children that have required like multiple like skeletal surveys and head imaging because there's been like multiple reports of exposure to like witnessed physical abuse. And so that's always, I always feel bad about that because that's a lot of, you know, radiation. But I think if it's just a matter of like repeating a blood test to check, you know, to make sure that they haven't developed a vitamin D deficiency, although it's very rare that you'll see a child that has a fracture related to vitamin D deficiency if they don't have other signs of rickets. So, you know, usually you would see that on the skeletal survey, for example. But yeah, I probably would repeat the blood test. And sorry, I think you had another question as well.
Yeah, my other question was, and then there's one in the chat as well. In the case where, well, how do you handle parents grossly? So do you tell them, my specific question is, do you tell them up front, I'm gonna let the DPG know you're gonna see a social worker in the morning, don't be surprised, expect it? Or does just the social worker pops in? Because I've seen different things done.
Yeah, that's a great question. There's also a great question in the chat as well that I'm going to try and address quickly. So basically, by the time I get called, I introduce myself. As I say, I'm a pediatrician. I work with our child protection team. We get involved whenever there's an infant with an injury or a young child with an injury, and we're trying to understand how it happens. So some parents understand that, others don't know exactly what's going on. But I usually try to, you know, identify who I am. And try to be like neutral and empathetic with the parents because first of all, it's not my role to be an investigator. And I don't know who the caregiver is. It's not my job to figure out who did it, if there was, you know, an inflicted injury. And also, yeah, I mean, you know, try and stay non-judgmental. It's our practice here usually to tell the family that we're going to signal DYP, usually either myself or the social worker or together we tell the family, you know, and I think usually parents don't get too angry because, you know, we frame it as, you know, there's a young child with an injury. It's our obligation to report it to make sure that the child is safe. And usually if you frame it that way, parents are sort of like understandable. I think the one exception to that would be if it was a case of like really, really concerning for inflicted injury, you know, very obvious injuries, serious injuries where you know that, you know, like the police are going to get involved and like the parents, like there seems to be like already some like aggressive behavior on the parents. I think I would maybe like do it more as like a surprise. Like I would call DYP and like they would probably bring the police with them. Like if there was a concern that the parents were either going to like flee with the child or get aggressive in the emergency room, then I think it might be justified, especially if there's like obvious abusive injuries that, you know, you call police and you call DYP, they bring police and they come right away. I have had cases where I haven't even interviewed the parents because you know, the injuries were so severe and so obviously abusive that they were going to be interviewed by police. In that case, I just, you know, you medically manage the child. But yeah, most parents are pretty understanding when you explain that you have a duty to report to protect, like to make sure that the child is safe, essentially. And then no, I didn't actually talk about demographic groups that are more likely to be investigated by DYP, but there definitely is evidence that there's bias in both the reporting and also the retainment of signalement and how those cases are treated. But like that would, it's a huge issue that that any one of us working in child protection struggles with because there's definitely a huge amount of bias in how children are and families are investigated and treated. But I think that would be an excellent topic for another talk, and I don't think I'd be the best person to talk about that. But yeah, that's a really big issue.
All right. Well, this was awesome. Thank you so much. If you have more, we'd be happy to hear the rest of it at a later date. So thank you so much. And I really appreciate you coming to talk to us. It was a great chat or a great lecture.
Thanks for giving me a second chance.
Oh, and more if you want.
Okay. Well, thanks guys. Have a great day.
Yeah, you too. Thanks.
Okay, bye-bye.
Bye-bye. Okay, so next up in our lineup is Dr. Anthony Robert, who will be giving us a follow-up lecture in the health informatics stream. So go ahead, Anthony.
Okay, I just wanted to check a couple of things. You can hear me well?
Yes.
Perfect. I'm going to share my screen. Wrong screen. Select screen two. Okay. Can you confirm you're seeing my presentation slide?
Yeah, I can see it.
All right, let's do it. Okay, so all right, thanks guys for having me over. I kind of imposed myself on Jake a while back, and I told him that, hey, I'd like to make a couple of talks in the fall because it fit my time frame. Turns out I just had five shifts in a row, and it wasn't the best time. But hey, I'm happy to present a topic that I love so much. So, last time we had talked a little bit about what design thinking was, and we really talked about more about understanding your role in health informatics and how you can be part of projects and innovations. I would try to define a little bit what digital health innovations were, health informatics, clinical informatics, quite theoretical, but I thought it was an important basis before we get going. And then I got some feedback from people saying it's very, semantic. But however, I think it serves a purpose. So today will be a bit more exciting, a bit more interesting. You had a lecture as well recently about data quality and analytics by Adam. And today we'll be more focused on how do you use this, this design thinking approach to improve healthcare and delivery. And I'm happy to have more presentations if you guys want in the future. Okay, so last time I had a survey, I asked you guys to report a couple of things to me, which you were thinking were problems which you noticed. Had about 14 people of you were answering, about 6 or 7 problems came out. And that includes, from an administrative perspective, outpatient follow-up about problems, delays in testing on the weekends, notes that are not legible, which the last part we're working on right now with improving electronic consult penetration. You guys mentioned some IT problems, including how things were slow and hardware and software problems, including the workstations, there's not enough of them, and too many clicks. So that's too many clicks will be something that will be relevant to today's talk. I guess talked about clinical protocol. So there's a lot of things. Obviously, we can't do all the projects in one shot, but we'll start with too many clicks, and we'll go with that one. If you look at design thinking, just to summarize and reframe it, it's a different diagram this time, but essentially involves concepts of empathizing with the situation, the scenario, understanding what the users are going through. And in this case, you guys are the users for some of it, so you know how it feels already. You know what the problems are, so it's a good place to start, get some legwork done. You have to really focus and understand and be able to describe one or multiple specific problem that you like to target. You brainstorm about it, try to develop a prototype, test it out, and see where that takes you. You need to do multiple cycles of it. So we're going to use this kind of a roadmap kind of framework called design thinking through other approaches on the problems that we can see. So again, that's the objective. And second part is to recognize even more how you can be involved in these projects. The 3 projects we'll touch upon in today's presentation will be medication prescription, which involves a lot of clicks, and sign over tool, which would be not really for a lot of clicks, but visualizing information, and a patient waiting app project idea. Okay, so this is kind of the ideas we'll go through in the presentation. So let's start with that. You'll see at the bottom where we are. So this one is about medication prescription. I just told you what design thinking was, and so really we're going to learn how you're going to collect information, define the problem, brainstorm about the ideas, but we're not really going to develop a prototype or test it for this part. So let's start. So let's say you're working on your next shift, you're sitting down, you're about to prescribe, and you're going to feel this, you're going to remember this to say, okay, why use Medjugorje to prescribe for my patients? But if you weren't part of Medjugorje, you didn't know, you'd want to sit down in the environment, observe users, and kind of understand their workflows, pain points. If not, you can set up a survey, focus groups, and discussing or looking at our training modules that we have to understand. But most of so as we mentioned, you have a leg up. Then you're going to analyze the workflow. So you're going to say, what do I do when it comes down to prescription? Let's take the pathway now of prescribing medication that the patient uses at home. So you're going to go and collect the DSQ list. You're going to transcribe this information into Medioge. You're going to activate the prescription. The nurses then, now you notice the color change, blue to green. So the green is going to be for nursing activities. She's going to see nursing activities in Medioge. And I'll show you what that looks like. That includes what's the stat med, what's the med LB tomorrow morning at 9 a.m. They'll be able to carry orders, physically, and then they're going to confirm it in Medioge to close the loop, right? So summary, this is what it looks like. You guys will remember, you're going to put in the prescriptions at the bottom down here. You can use this tool here to search through and filter information. And then the nurses see this. So this is their nursing activities, right? This is electronic. This is great. If you're a nurse sitting at your desk, you want to know it's 8 a.m. for this patient. What do I have to do? You have to monitor the chem strip, give them their metformin, metoprolol, ranitidine, and there's another dose later on at 6. So this really facilitates their work as opposed to paper workflow where they have written somewhere, they have to go find that chart or find a second chart in some places, or have their nursing orders chart and then look for every patient one by one. So this electronic version with lights, and then you can click on it. Nurses can click on it and say, I've done it. I'm going to move this for later because patient is not in the room. And you can really document timestamps, which are going to be collected electronically. And we talked about how data needs to be collected properly if you want to analyze it later. So this is an example where it's electronic, therefore it's easier to collect it and do research and projects around it. Okay, so now I'm going to start defining some of the problems. So I just really relisted the same items in a box. They may be getting smaller, so don't worry about reading it too much. I'm going to tell you what these are. But essentially, it's the same pathway I just showed you. And if you sit down and think about each of the problems, you can think about the first problem. I need to sit down at a computer with my keys in the other computer in the back because I had to move stations. And then you have to kind of go open the software for the DSQ, enter the patient's brand queue, and then you're going to be able to see their data. Another problem that you'll have is you need to, sorry, I forgot to change this part, but you have to electronically transcribe. So you're manually putting information in one by one, right? So that's the second problem, that you have to click, enter acetaminophen, enter the diltiazem, and so on. And sometimes we see this and somebody forgot to activate the prescription that they entered. It still happens to me once in a while, less and less, but unfortunately it still does. And that's when especially when you're trying to go fast, or if you have too many prescriptions, sometimes you accidentally forget, or sometimes we purposely don't want to re-prescribe medication. So but there's a task there that could lead to problems, and then we're not going to analyze the nursing workflow for this part, just focusing on the physicians. Okay. And then there are alternative pathways, right? So you can see, okay, this is what we do now, and maybe there's another site where they print the DSQ orders directly on paper, and then they activate by signing it off. The nurse has to manually transcribe. So here I changed colors. Anything in orange is new, different from the above, and then the rest is about the same. So the nurse, if they get it, they could enter it in electronically in Medioge, for example. So it's their electronic transcription instead of us, and then they could be doing the rest as they would above. Or you could print a paper form, the physician kind of signs off and now it's active, and then you transcribe it manually into the nursing chart or booklet of all the orders. And and they would carry on the orders, but then they manually have to close the loop by going back and checking it off. So the reason I made these lower ones wider, because there are problems with each of these workflows that you're adding. Let's say it's anything that's manual, that's paper, requires flagging, requires the nurse to find it and see it. And if they don't see it, it takes a bit of a delay. They forgot to check it off by hand because it's in the other patient's chart, or they couldn't find it. They used the wrong chart. So all kinds of problems can happen. Hence, I kind of made the boxes wider to show potential challenges. Okay, so then you say, okay, well, that's the workflow. What are potentially a better workflow? So here's an example of the first two that I put. A third one is a new one that I'm adding here. What if you could import from the DSQ directly? So you don't have to, maybe you don't have to put the key in, or you do, but once you have the patient open in front of you in one system, let's say Medioge, You click on a button that says import from DSQ, pulls all the orders in, and then you can sort of activate them right away. Therefore, you don't have to electronically prescribe, and the nurses continue their workflow. To me, sounds like a minimal change in the workflow. So the nurse's workflow doesn't change. Physicians now are more efficient in their time. And you'd think, okay, that's a great project. Well, for this one to be prototyped and tested, you need to get a third-party system or build one that's the interface between MedSurg and DSQ, because it doesn't exist yet. You can build it inside MedSurg, or you can kind of use a third party. So we're kind of looking at an approach. It's a project that's been slow to move because of all the implications with medication and the ministry and the hospital. But here we're just really focusing on understanding how the initial idea of identifying a problem can lead to solutions. So we found a product that was worked on with McGill researchers called RedRx. And this happened because we were just exploring the topic, talking to people, and somebody brought up the point, hey, this system, this middle portion that doesn't exist, could be leveraged from another company that has a product here at McGill, and it's still in a research phase. But that product could sit between the DSQ and MedSurg. So you would import it via MedSurg. So in MedSurg, you click a button, it opens this RedRx system. You connect using maybe some username, password, maybe the key. Then you visually see all the meds, and you just push to MedSurg, and then they're activated. So it's a simpler workflow, easier, saving time. Obviously, all the benefits are there. And I can't really think of new challenges or changes in the workflow that affects the nurses here. And for physicians, there may be some challenges if the RedRx system goes down, or the other problems that come along the way in terms of software. But if it's well implemented, I would see this being a huge plus and huge improvement in patient care. Okay. So before you start doing this, then you need to have your goal. So what is the goal of doing this project? And then you go, okay, from a healthcare innovation perspective, from the clinician's perspective, you're using some IT to do what? Are we improving treatment, diagnosis, prevention, education, research, outreach? So here I would say, you're kind of preventing medical errors, you're making the overall care more efficient, maybe safer. So it's definitely, and these would be the targets you'd set yourself up. There's methodologies to use this, which is outside the scope of this lecture, but you need to have your goals clear so that when you're working on them, you can measure them before and after, see if you successfully achieve it. Okay. Another side of MedSurg, that could be an interesting project that could be done. And this one is not something we're working on actively, but if anybody have an interest. So how we have to order medications in MedSurg. So you can say, well, why don't we have all of these lines pre-filled, right? If you want to order an ACL as a bolus or as an infusion, you can have each line already pre-filled in MedSurg. So that's about 6 lines here. But we know in MedSurg you can see about 5 already. Maybe there's a Ringer's lactate and maybe there's T5. Should you only have 2, because now you can easily see them if you search for an ACL, you see 2, or should you have them blank so that you can fill in? And you can start counting the number of clicks based on the scenario. So you can simulate a case where you need to prescribe a patient, 250 cc bolus and a 50 cc infusion. In another scenario, we want to give 75 and have different users sit down, watch them do what they do. And in a test environment, we can create these different search outcomes. When you type in ACL, you see different things. So you can search these, set up this different setup, and get someone and count the number of clicks and say, okay, overall, based on acute care, walk-in patients, so on, these 5-6 scenarios, we get better click efficiency using maybe just 2 versus 6, or just put them blank. And these are something you can measure because you want to be more efficient and decreasing clicks. Again, we can think about protocols for asthma, GI bleeds, migraines, where instead of selecting each meds, you can just select a protocol, and some of these already exist. Some could be made better. So just to give you a perspective of, saving clicks in many ways, whether it's prescribing from the DSQ or optimizing what's already in there, could be an interesting project where you guys already know the pain points and probably have ideas, and you can just find a way to test it. I'm going to pause here, see if anybody had any questions specifically about this one. Otherwise, I'll get moving to the other one.
I actually asked one in the chat. So
yeah.
So I was in Lévis, I know MedSurg was a platform that we were using for all. So it was like a one platform thing. Would that be a possibility?
So this was at some point we were doing that, and I don't know if Mark is on the call, can correct me, but with MedSurg, the nurses still had to manually go from MedSurg to the stickers, but in Oasis you can set it up that you can print orders directly, and I forget where the loop is, but there's an optimization that the hospital required that everybody moves to Oasis for order entry, plus there's some facilitation. So I'm not sure which of the two were the stronger element, but in the end, we had to move to Oasis. So that was sort of a requirement for the hospital, such that, you know, all the orders are now standardized and they're on in the system, they can be tracked and so on. There is a loop that could be developed so that everything is done in measures and sent over. But you know, if you in the hospital you have two environments where you do the same thing, it's not ideal from an IT resource utilization than to just have one system for prescription. Obviously, one system for everything would be better, but you know, if you're really just focusing on prescribing labs, you don't really want to maintain two lists of labs and you want to use one. So it was a bit of a requirement to move that way. Okay, all right. So I hope that answers. I'm going to move on to the next topic. So sign over, right? So all of you know, and again, same, it will be the same approach, right? Empathize scenario. You see your staff or yourself, you guys are starting to take sign over. Use a tool where we put information in, and different environments, there's no tools, or so everything is by hand. You can define some problems from that perspective, you know, come up with some ideas, prototype it. Okay. So, all right, got those. So, you know, this is the image of a sign over tool at the in UHC. And you know, some of this is all just, there's some names, but they're not all real names. None of this data is new, it's old stuff. You know, you have a patient that comes in and they are, you know, sick. You transfer the case at the end of your shift and you put some information in. So without digging too much into what's in here, there's often a question about what is the level of care of the patient. You'd wonder that this information be easily retrievable and shared with everyone. We recently moved to using Oasis for entering level of care, so there's no more paper forms. So just to remind you guys, if you go in Oasis, you order by a document type with the description, then one of them will start with level of care. There's a French and English version. So, you know, you have a level of care for the patient. You have, you'd ask yourself, you know, what labs do I have to follow up for this patient? You know, is everything done? You know, what was it specifically with the INR today, or the potassium or the lactate? You may have specific questions based on how you receive the story and what you're worried about as your differential. You may want to know what kind of medications were already given to the patients. And sometimes you feel like, you know, it's in the system. Why do I have to repeat it? And sometimes you have 5 patients that all have, you know, URTIs. Some of them have COPD, others don't, and they all have lung cancer. You may forget or not know exactly. So it's going to take you a moment to think and remember, okay, this patient has this, or you're going to look it up. And then some of us use the sign over tool as a place to put some documentation that you'll reuse later. So if you sit down and you think, okay, what could we do to make sign over more facilitated and better? And these were the problems that I was identifying. And essentially it comes down to there's information that's available in MedSurg that is not being displayed on the screen. So we came up with a slightly bigger version. I think you can see this, yeah. And you know, you have now the same patient that comes in, and you're now able to see all the information you want. So this is not built yet. We actually spoke to Lejebec. We provided them the screen. We are in discussion of moving towards this. But take a look at here. At the top, you would have the level of care. It may have to be free text for now because there's no loop from Oasis to pull it out. But we discussed with nursing, and there was a discussion that they need to maintain it, or you would just write it there and it's there for a long time. Now the past medical history is a bit better laid out. You can actually see a list. The presenting complaint that the patient came in for may be useful. So this is the information about their presenting complaint. Most of this information here. The reassessment priority we thought would be important. Sometimes you hear the story and you get told, okay, this patient is actually quite sick. Please go see them soon. And you may not remember after getting 20 patients which one that specifically was, or you know, maybe one is easy. Let's say you have 5 of them. So you can set yourself a reassessment priority. Click this button to go to OWARD and then import or copy over this information there, or have OWARD open from this window so you can continue charting by looking at this information. We thought, you know, the list of active medications could be populated as a list. More detailed labs with color-coded of anything that's abnormal could be interesting to see. And now all of a sudden, sign over has become a lot more simpler, a lot more clear, a lot more efficient. You can also see the list of pending labs and pending imaging or their statuses. And most of the information is today available, short of the level of care, directly in measures can be pulled electronically. This idea came really from looking and empathizing with the scenario. What are the pain points? And again, I didn't go and do a big survey about it initially. I sat down and I said, what are my recurrent questions, or what are the questions that are asked to me that I don't remember? So again, when I told you guys earlier, you guys have a great role to play in initiating, collaborating, or being part of the IT projects with minimal to no IT backgrounds because you are clinicians who use the system. Yes, okay. I'll stop and pause, see if there's any questions. I'll on to our last one.
There are none in the chat for now.
So Anthony, I have a question.
Always.
Always, yes. I'm looking at some of the stuff there, and there's information I don't want.
Yeah.
So how do you correlate between, because when you do sign over, there are some staff who want minimal, and then there's some staff who want too much.
Yeah, so
for example, some of the stuff I don't want, if something's normal, I don't want it. In terms of the labs, the abnormals for sure.
So that's an important point, right? So now this comes to how do you prototype a system that every user would be happy with? So the answer is there is no such thing that every user would be happy with, and they have to go with features and functionality. So we did a survey and we asked, what are all the things that you like to see? And we got quite a bit of interest for most of this information. So the goal was the majority would like to see it, so it's there. Ken's point is very good. I may be someone who wants less information. So at some point we were thinking, could we have a button that minimizes or blocks some of these screens? So if we could develop this in-house, and if we had enough, we could add all kinds of bells and whistles, making this fancy. However, we have limited budget, and MedGeorge as a tool is a bit of an older, archaic system that's not as easy to make it as dynamic as a cell phone or mobile apps. So we're a bit limited. So the thought was, what is really normal? Is there a normal that is truly normal? So let's say hemoglobin is 120. That's normal. But what if it was 160 earlier? Well, that would flag as a change, right? So there's too much of this logic that needs to be built in of, okay, well, what is or what is not? So we figured we just show the numbers, and if the trend is abnormal, we're going to highlight it. Or if there's clearly outside the normal numbers, we highlight it as well. So we use more of simpler logic because it ends up being complicated to build. But that was the idea. And again, it's easy to ignore information. So often people tunnel vision into this box only and don't look at anything else. So I think it's essentially important to have the users be happy with it. So you have to look at what was the goal for this particular project. If you're going to improve the sign over, what do you want, right? So we talked with the QI team and they had some specifics, and we said, okay, with more of this information, sign over quality would be better. So we're going with measuring quality. If you are building this tool for physicians' interest, you definitely want their input from the beginning till the end. So along the way, we got some feedback. We had a CQI team that looked at this again. We had about 20 people, 20 physicians who took the time to give us some information, feedback about this particular layout. So in the end, that's what we get. But thanks for your comment, Ken. It brings up an important point that users' feedback is very important along the way.
Just before you go on, Anthony, I was also just curious. I know that you said that budgets is an issue and such, but potentially could it be sort of left open down the line that maybe this could be user specific, like, because we have to log on to MedErge, right? Like you have an account. So technically, could you have parameters specific to you? Yeah. That just, it's not a logic anymore. It's just that, well, I guess that would be logic, but you have your settings, and then whenever you log in, yeah.
Yeah, so user configure it in general in EMRs, and if you look at some of the readings and literatures out there, user configuration is a great idea, but they're moving towards generalized configurations that can be modified later, because most people will never take the time to sit down, spend about an hour to two to figure out what is it that they want today. Okay, they want to change it. They'll just say, okay, well, can somebody do this for me, right? So, and then you kind of come back to having a global setting. But also with MedErge, this user customizable feature is not present. There's no interface for it for users to go do their settings. So, in an ideal system, you would have some customizability, but not too much. But yeah, within the system that we're living with, we're kind of limited. All right, so let's move on to now away from us as clinicians, but about patients, right? So we'll go through again the same cycle, asking us still the questions and kind of seeing. And this time we'll show you a little bit of a prototype and how one can build prototypes. Okay, so how do you feel, or how do you think patients feel when they're in the waiting room? Some of you may have been patients, had family members there. I tend to take my family members to most appointments, and I always did that for the last 20 years or so, especially my parents and grandma. And I often see what it is, the experience in the waiting room, when it's busy, when it's not. And I know up until recently, I never pulled any strings to get through what I wanted, but and then you really got to observe what's going on. So, I have some ideas, but I'd be happy to hear some comments either in the chat or if you want to voice out. What do you think our patients feel when they're sitting in the waiting room? What are their emotions and feelings, the situation?
They annoyed, they don't know how long they'll wait, and they'll anticipate a long wait.
Yeah.
Untreated pain.
Yeah. I see here a pool table, I'm guessing, is something they like to see, or feeling stressed, right? So, I'd agree with these feelings, right? The patients there are frustrated. They don't know what's going on. They think we don't care because they don't see us coming out and going, all right, everyone, sorry, we're a 12-hour wait delay and stuff. And there's been reasons why we don't give some kind of information. And, I'm not saying that they're right or wrong. Essentially, there's been decisions made why we interact in a certain way, but the patients have no idea. Their expectations is, well, there's nobody coming to see us in 5 hours. Like, they don't care. Yes, they're busy, but we're humans, and they have a lot of feelings like that, right? So from my perspective, I'm thinking that, okay, the problem is that patients are sitting in the waiting room and they can do a lot of things. So one, yeah, they have some time on their hands. They could look at information, they can give information, they can absorb information. They have a phone in their hands, so they can use that to gain some insight. They want to know what's going on. They want to know the cause of the delays. They want to be able to share information with their family. They want to share information with us. Oh, I remembered something I didn't tell you. Oh, it's gotten worse since I last spoke to you. And right now what they do is they go bug our triage nurses or the nurses and ask them questions and kind of slow their work down. So we were thinking about ideas, what can we do to make some of this better? So we had 4 people sit together, and then we kind of thought, so we said, okay, what if we had an app that could, show the status of the investigations and consult? That's currently in Medjugorje. We can probably show that to them so they have better information, or maybe exchange some specific information, or is this, what is the goal of this project, right? Is it to improve patient experience? Is it to improve patient information flow? Is it to help our nurses work more efficient? And then we said, okay, there's a lot of things. Okay, this could get really big. So then we said, okay, let's sit down and brainstorm. So 4 of us sat down. One had a hat of a patient advocate, one had a physician's hat, a fellow was there, and a nurse. And then we said, okay, what could we do? So you don't need to read this, but essentially just to show you that we had a little bit of sort of a board where people could write different thoughts, and we kind of organize them. What would the patients want to see? What would they want to share? What kind of input they want to give us? What do we as a team want to see? What do the specialists want to see? And then we kind of went around in circles and had a meeting to kind of agree and disagree about what we thought could be priority. And I had this in mind as well. I've seen this before, and you guys have seen it. And you know what's going on with your Uber. That's amazing. The car is not even here, and the food is not even made. Every single status. The food is being prepared. The food has been picked up. The food is on its way. So then 10 minutes, 5 minutes, 2 minutes. And it's great to know all these statuses. Or Bell, I just got this today, and it said, your appointment has been ready, and then I'll get another notification when the technicians is coming on their way. So I thought, statuses are really good. So there's a tool out there called draw.io. It's changed its name, but the same website still works. Or you can use any tool to draw and mock up some stuff. So I did that. And the prototype makes things more clear, and people can see the impact and value of it. So I'm going to show you, but we showed this to a few people. This wasn't shown to everyone at this time because we're just trying to see what we can do. And we have to get the hospital's priority because it has to connect with Medjugorje. And so the completion of the project is complex. However, it has to start somewhere. And again, you guys have a great role to play in this, okay? So here's an example of what we thought. Patients can have an app. It will be their virtual assistant. It shows them there are six milestones in their journey, from pre-triage to triage to clinical evaluation, treatment plan to follow-up. They're green at the first one because they just arrived. So they click to start their trajectory, and then they ask some information. Okay, what is your name, last name, RAM-Q, some information like that. You fill that up, and you can say what medications are you taking. And this could potentially pull from a previous materials, or if we don't have access to it, we can maybe connect to Carnet de Santé or the DSQ. Ways to get it. If we do, we can put it, they can check it off. They can add other medications if we wanted to. They can check their allergies. These are all just ideas. None of this is done. So just to give a perspective. Is your GP still the same? Do you have one? Did you change? All information that we as clinicians like to know. And then they get this notification where I'll be sitting down. Okay, it's triage time. You can now go to room 5. So sometimes we call patients, they'll hear. Some patients cannot use a phone, some patients cannot hear. So obviously there's scenarios to look into. But in this particular case, imagine that a patient is able to use their phone and quite agile with it. So they walk over to room 5, and then they come back and they sit down. Okay, well, your triage has been done. You're level 5. Wait time for others that are similar to you. Now a bit of context, right? Rather than saying it's 12-hour wait time and the guy who has an MI leaves the ED, now you're saying for those who are category 5, you may be at this wait time. Again, this may be giving specific numbers is not the goal here. The idea is to say giving some sense of understanding how long they have to wait. And this could be done as a number, a range, a block, some ways to give them perspective. And now you're just waiting for your medical evaluation. Okay, your medical evaluation time has come, go to room 5. And then you sit down and you wait, say, okay, this is what's going on. Okay, my labs are going on, my x-ray's been done, I'm still waiting for my CT neurology. Okay, family member asks you, you can tell them, okay, well, look, I'm still waiting to see the consultant, this is what's going on. Often patients, family members will call the ED, ask the nurse, hey, what's going on with my family member? I want to know. And we can't always give that information. But here the patient would know. And then at some point, okay, your treatment plan has now been set up. You're getting this Macron bolus, you have an IV going on. And again, I'm not saying that there's a connection with the IV machines to the patient. Again, this is not about how to get it done, but this is the type of information we thought could be beneficial to our patients. Now your treatment's done, everything's done. What are you waiting for? Well, the consultant hasn't come to see me yet. Okay, here's your discharge instructions. You're all set to go. The follow-up will be on Tuesday at 3 p.m. Patient now had a great experience, enjoy their time. Did this make clinical care better? Maybe, maybe not. Did it improve the care for the nurses? Maybe, maybe not. But you have to have one clear goal when you make a project. You can have sub goals, but you can't cover all the goals in one shot, because otherwise your project gets too big, takes a lot of time. This is why, as Jake pointed out, could we leave some time later to add more features? And the answer is always yes. There's this not a new approach, but it's an ongoing approach in software development or in agile processes, agile project development. You may have heard these words. It really means that you're doing things in cycles multiple times. Think of CPR, where you go one cycle and a second cycle and a third, and you go around and around, starting from requirements. So design thinking kind of comes as a precursor, as a first step, and then you kind of gather your requirements along the way. When you get the prototype, you design it, develop it, test it out, and see what's going on. And you kind of go in cycle, make changes, improve it, make it better, make changes and improve it, make it better. So then you test it out and you build it, and it allows you to share this with other people and get some feedback. Okay, so back to you. So now I hope you have a better understanding of what is design thinking. You have some idea of how the workflows are in the clinical environments here. That gives you a head start. I just want to show you a couple of screens here. This is the workflow for a clinician, right? You log in, you sign over, you pack patients, you visualize data, you enter some data, documentation. Well, similarly, there's all these workflows for patients, nurses, physicians, coordinators, and everyone. And we had some projects or ideas of projects all over the map for different aspects of care. And I think this is where you as clinicians would probably understand all of them and their value. And if you have some IT interest or some IT training, you can take that to the next level and be more involved. So we can do more as a group rather than having one leader of IT and everybody else kind of using the system. To have multiple people with multiple levels of experiences and interest in participating in different projects, get a lot more things done. So there's more lectures I can do if you guys are interested, but what are prototypes? How are they done? How do you develop software? how AI can improve clinical workflow or speech recognition. So let your chiefs know. Consider doing an electives with us. And I think I went a little over time, but hope that was useful.
That was awesome, Anthony. I see that Dr. Doyle has his hand up. I would request, Dr. Doyle, could you type that in the chat, because we're a bit over time and we have like a strict start point for a resident wellness event at 10:30. So
No problem.
I think I might move it. Thanks. Yeah, but by all means, put it in the chats, and yeah, and hopefully Anthony can stick around for a bit. All right. Thank you. That was awesome. So like really cool to see what developments are in the works. So next up is Rada and I, and we're going to be presenting a trial. And so I'll let Rada say what trial that is, and we'll get going on that.
Good morning, everyone. Sorry, Jake, can I share my screen?
You should be able to, yes.
No, Rada, everybody can, but not you.
I have tried to make this difficult for you specifically, but okay, you figured it out.
I figured it out. Thanks anyways. All right, well, can everyone see and is it clear?
Yeah.
Oh, good.
All right, so as you guys know me, I'm Rada, I'm the R2 in the 5-year program. I'm gonna present a journal club today with Jake. So I'll quickly go over the topic. It was an article that was published in the New England Journal of Medicine, early 2020. The randomized trial of 3 anticonvulsant medications for status epilepticus. So just briefly before I go on to presenting the article, I just want to go over the current guidelines in terms of managing the status epilepticus. So you have your initial assessment. So initial therapy. Yeah.
I'm so sorry to interrupt you, but we see the rest of the screen, so we don't see very clearly what you want to show us on the.
Oh, sorry.
Could you put it maybe in presenter mode?
I thought I did. Is that better?
Perfect.
Yeah, that's good.
Yes, right. I'm not like Anthony. I'm not an IT guy, so. All right, there we go. So in terms of initial management, you start off with your benzodiazepines, be it diazepam, Ativan, or midazolam. Then you proceed to the second line, which is either fosphenytoin, valproate, or Keppra. And then you proceed treating accordingly, and if all else fails, proceed on with intubation and then continuous either propofol infusion or midazolam. So this is just the basic outline of how to proceed with status epilepticus. So based on this introduction on this trial, so currently there is evidence for benzodiazepine as first-line therapy, and this evidence exists. However, 1/3 of patients do not respond to benzos, and there are limited studies for benzodiazepine refractory status epilepticus. So guidelines currently emphasize the importance of early control. However, this choice of the second-line therapy hasn't been studied based on efficacy and safety. And the importance of early termination reduces the risk of cardiovascular compromise, ICU admissions, respiratory complications, mortality in children, and neurological damage. So as I said, second-line therapy, it's either Keppra, fosphenytoin, or valproate. And only fosphenytoin has been approved by the FDA for this clinical indication, and none of these have been approved for children. So the ESETT trial, which is an established status epilepticus trial, it's a multi-center randomized blinded comparative effectiveness of Keppra, fosphenytoin, and valproate, as designed for the treatment of refractory status epilepticus. It was conducted by the Neurological Emergencies Treatment Trial Network and the PCARN, and it was performed under the investigational new drug application with the FDA. So data was collected from 2015 to 2017, over 57 emergency. And I'll quickly go over the inclusion criteria. So it was age above 2 years old, including all age groups, and they had sub-specified different age groups, for example, 0 to 5, 6 to 10, and moving on until adults. And they described it as a seizure that had been treated with acceptable cumulative dose of benzodiazepine, and you can see in the table below what they deemed was acceptable. And the seizure had to be lasting more than 5 minutes, or they had recurrent seizures. And to include them in the study, they had to have received their last dose of benzodiazepine either more than 5 minutes or less than 30 minutes. And they also accepted pre-hospital management of seizures, for example, IM midazolam. Excuse me. And the exclusion criteria was if the seizure had been precipitated due to a major trauma, hypo or hyperglycemia, cardiac arrest, or post-anoxia. Pregnant women were excluded, incarcerated patients. And if they had been treated with an anticonvulsant during this episode prior to the start of the trial itself, or the intubated patients and patients who are allergic to or had inborn errors of metabolism, renal failure, or liver failure. So in terms of the treatments, all three medications were provided in a used medication box that was randomized and randomly allocated to the patients. So the research team had a specific designed box that was placed next to the patient. And once they deemed that this patient was eligible for this trial, they opened the box and it contained a protocol assist device, which automatically activated the research team, the research nurse, and everyone that was trained with it. And in that box had a specific body weight infusion rate from an enclosed chart. And all the drugs were administered over a predetermined 10-minute rate. And the vials all looked identical in terms of packaging, formulation. And in terms of management of the case itself, it was done by the ED physician. So rescue therapy was given as clinically indicated. And the ED physician was able to unmask the drug itself, either after the primary outcome, after 60 minutes where you get a seizure resolved, or emergency unmasking if there was any clinical indication to do something else by the ED physician, but that was considered a protocol deviation. So the intervention groups were the Keppra and the valproate, and the control group was a fosphenytoin at these doses. So they had decided what their primary outcomes early on to be is an absence of a clinical obvious seizure and improved responsiveness 60 minutes after starting the drug infusion. And that was determined by the emergency physician. What they defined as clinical seizures was generalized tonic-clonic, focal, nystagmoid, or generalized segmental myoclonus. And improved responsiveness was either the patient had purposeful response to a noxious stimuli, they were following commands, or they were verbalizing. So secondary outcomes they took was time to termination of seizures, ICU admission, and length of stay in hospital. And they also had in these protocol assist devices were audio recordings that were placed in the room so they can better quantify of when the time of the termination of the seizure. They also documented adverse outcomes, life-threatening hypotension, arrhythmias, intubations, anaphylaxis, seizure recurrence, and death. So in the analysis, I won't go into too much detail about the statistical analysis, but their null hypothesis was that all three drugs were considered equally likely to either be most effective or least effective. And they had a predetermined criteria for most or least effective. That was a probability of more than 0.975. And then they had three subgroups. So the intention to treat, which included all but re-enrollment. So any patient that presented with another status epilepticus were not included. Safety analysis, which included all the patients, even the ones that were re-enrolled. And the per protocol, which excluded the re-enrollments. If they had deviations to the protocol, they did not receive the assigned drug. And this is just basically algorithm of how the patients were filtered through. So initially I had 400 patients, but then they ended up with 384 unique patients. And they were assigned randomly to all. So at the end, you can see how much it was in the Keppra group and how many were included in the per protocol, intention to treat, and the safety analysis. You can see that is the same for all the other drug groups. So the baseline demographics, they made it as similar to all groups as possible. So the mean age was around 33 years old. And you can see the other age groups, they're all similar range. All these patients, around 87% of them had a final diagnosis of a status epilepticus, 10% had a non-epileptic spell, and 3% were unable to agitate. So I'll move on quickly to the results. So the primary outcome, which was the absence of a clinical seizure and improved responsiveness. As you can see, the percentages are all similar. So 47, 45, and 46 respectively. The bottom number is the posterior probability that the drug may be most or least effective compared to the others. And it's 0.41 for Keppra, 0.24 for phosphatidone, and 0.35 for valproate. And if you remember, their probability criteria that they had decided on was greater than 0.975. So none of them had been proven to be more effective or least effective compared to the other groups. And it was similar in all different analysis. So the intention to treat, the per protocol, and the safety analysis. This is just a diagram in the article that summarizes what I just said, including the secondary efficacy outcomes. So the admission to ICU is around 60% for all groups, and the median time for cessation of the seizure was around 10.5 minutes. In terms of the safety analysis, listed are the adverse events that happened, and it was deemed that there's no significant differences amongst all the groups for safety outcomes. It was noted that intubation was highest in the phosphatidone group, but they deemed it not statistically significant. So in terms of the discussion, there's no significant difference in seizure cessation amongst the three drugs. Around 50% of the patients in each group had a seizure that had stopped, and no significant difference in the safety analysis. However, the time to cessation had limited data, as some protocol assist devices were not used properly in terms of audio recording, so they didn't have the proper amount of data for time to cessation, so they disregarded that from the results. And just quickly going over the conclusion. So 384 patients, 3 different drugs, all around the same amount of responsiveness, 47, 45, and 46%. I didn't talk about the limitations in the study. I will leave that part to Jake for the limitations and the critical appraisal. So thank you. And if you guys have any questions, let me know.
All righty. Okay, if you can stop sharing your screen and then I'll share mine.
Sure.
Unless I can do that. Okay. All right, so, I mean, let's just get into it. So, you know, we're talking about status epilepticus. So, let's talk about the strengths of this study first, and then we'll kind of get into a little bit more of the discussion of the results. So I think that the study asks a clinically important question. You know, what are we going to do about status epilepticus when it presents, and what medications as second line are best? The population of the study does focus on those presenting to the ED. The patients were adequately randomized, and this process was concealed from the clinician. So, I mean, I think it's pretty impressive that they were able to conceal the drug, infuse the drug over the exact same amount of time and make it look the same. So in essence, you know, all drugs were infused over 10 minutes, and both the patient and the physician were blinded from this. And I think that's a pretty impressive undertaking, especially when it goes across 57 different sites across the country. And I also do think, on top, like, just with that being said, it being a multi-center randomized clinical trial increases its external validity. All right, so these patients were analyzed into the groups to which they were randomized. There is a large sample of enrollments, even though they did stop due to futility assessment, but still a large enough sample was reached to reach a conclusion. I like that they had weight-based dosing of both benzos and antiepileptics, as opposed to just having one set dose. They changed it according to patient. And based on the analysis of each of the patient population, or the sample size or samples, the baseline characteristics of the patients were balanced between the three groups. But so limitations to the study, the gauging improvement in responsiveness is a subjective outcome. So you know, many clinicians have quite a bit of experience in assessing seizures, but this is still left to the clinician, him or herself, which can take away a bit to the consistency of what improving responsiveness is. And although there was a good number of patients involved in this study, the study was stopped early. They were looking for 720 unique patients, but they stopped at 384. Again, that was based on futility. They found that there just really wasn't any difference and it wasn't going to change. 27% of patients, which is 108 patients, were had deviations in their eligibility criteria, but they were kept in the primary analysis. But you had deviations in terms of the amount of time that had passed between the last benzo dose, and it could have been too soon or too late afterwards. But these patients were still kept in the analysis. In approximately half of the cases, unblinding was necessary. This is because the second line agent that was given initially was not working. So the physicians needed to know what was given in order to provide the next anticonvulsant treatment. There's also the concern that even though dosing was weight-based, the 10-minute infusion for the max dose of phosphonatoin may have been suboptimal in some of the patients with weights that were greater than 75 kilograms. And it is noted that the benzodiazepine cumulative dosing was somewhat small. So here's the listing of the max dose of diazepam, lorazepam, and midazolam. After reading reviews, there are quite a few physicians who said that they would have provided more benzo before deeming the benzodiazepine to be a failure. On top of that, these patients were only assessed in 24 hours post-event. So the long-term survival and neurologic function wasn't studied in this trial, which can be something like that's unfortunate. So same picture that Rita showed. So what do we do with this information? I mean, so they're all the same. And do we think that these numbers are good? So glass half full, glass half empty. The glass half full is, all right, great. All the options are the same, which means it doesn't matter what I pick. I'll just the first one that I remember, I'm just going to use it. But the glass half empty is that none of these options are very good. I mean, if 1/3 of patients who receive benzos remain in status, and then half of those patients remain in status, that means that if you do the basic math, 20% of any patient who is in status will remain in status. And that's not a good thing. That's 1/4, or sorry, 1/5. So you have, and then on top of that, this study kept patients, they were observed for 60 minutes, which is a long time to be kept in status. So which one should we choose though? So if they're all the same, is there one that's best? And I think that a lot of people would agree that if there's no discernible differences between anti-epileptics, the choice of one over the other should be based on which one is safest. So phosphonatoin is known to cause hypotension and or bradycardia if administered too rapidly or in patients with underlying cardiac comorbidities. My previous rotation was at the neuro ICU, and someone coded after being given a substantial dose of Dilantin while being in the observation unit. And Dr. Mark Engel, I quote, said he considers Dilantin to be poison. So, different people have different opinions. Levetiracetam is a newer drug, so it doesn't have as much research into the side effects, but currently it still does have the smallest side effect profile. But it must be noted that given what I've just said, this particular study, which is quite broad, did not note any statistically significant differences between anti-epileptics in terms of adverse event rates. So, going on to Hippocrates, this is the side effect profile of each one of these medications. I'm not going to list all of them for you, but levetiracetam has the smallest list. So I think that would be where I would go with this information, is if they're all the same, I think Keppra would probably be the go-to for me as to what I'm drawing from this study. But, okay, so going into another issue with this study, that the question is, does permitting someone to be in status for 60 minutes to break the seizure make sense? I mean, there are studies to suggest that permanent neurological damage, like cerebral hyperfusion, hypoglycemia, hypoxia, leading to neuronal damage, can occur at 30 minutes, not 60. So on top of that, you've got aspiration risk that increases. You got an unprotected airway with these patients, rhabdo, hyperthermia, hyperkalemia, acidosis. You've got cardiovascular stress of the seizures. And on top of that, if the patient is actively seizing, you're not able to order other tests that require the patient to be still. So maybe already the target should be 30 minutes instead of 60. So regardless of that, regardless if we say 30 or 60, I think this study also highlights a question as to are we handling status epilepticus sufficiently well? Because in the best case scenario, so these patients were coming in from EMS, Urgence Santé, and they had already been seizing for upwards of 15, 30 minutes, an hour. Let's say you witness this patient's doing okay, and then you witness the patient seizing. Well, initially, the idea is that you should be waiting 5 minutes just to see if this patient is in status. So you get a benzo ready, you wait 5 minutes. Well, the patient's still seizing at 5 minutes. So you give the full benzo dose. Like just say that you give the whole thing. You don't do it in parts. You wait 5 minutes to see if it works while getting an anti-epileptic ready. The patient's still seizing. So that's 10 minutes. And then you need to give the anti-epileptic, which let's say you infuse it over 10 minutes. And then the median time from this ESETT trial to seizure cessation with each, if it worked, was approximately, you could see 7 to 11, 12 minutes. If the seizure persists past 20 minutes, there's no difference. So we're only getting about, like on top of that, we're getting about 50% efficacy on these second line agents. So there was a nice, from Palmcrit, there was a nice diagram to sort of illustrate this. So in a fantasy land where we are able to witness that seizure and start the timer immediately, we're still half an hour at best of actually seeing if the anti-epileptic works, our second line treatment, and it's only got a 50% efficacy rate. So this might call for a paradigm shift. I mean, even in the best case scenario of the current algorithm, a status seizure is not going to be stopped in less than 30 minutes. So it might be time to start reassessing how we approach status epilepticus. So, I like to think that the obvious next choice that I think we're all thinking of is just shock the patient. You know what I mean? ECT, because I think if it works in the heart, it probably works in the brain too. I'm joking though. That's the total joke. Totally kidding. I'm actually thinking that we should start incorporating anesthetic agents maybe earlier. And this is something that Palmcrit, the bottom line, a bunch of different physicians who have FOMED resources will talk about that. Maybe you should consider giving the benzo and the epileptic at the same time. If the person's in status if they cross the 5 minute mark, they're in status. So this is a difficult seizure to handle. So give the benzo and get the anti-epileptic in. Incorporate anesthetic agents like propofol or ketamine earlier into your algorithm. If the patient, even if the patient ends up getting intubated, think about it, that's going to happen faster. So you're not going to wait for that patient to get to the 45 minute mark and then eventually decide that you should intubate this patient. So again, from Palmcrit, which I really liked these diagrams. So if you look at it, you have 5 minutes and see how things go. You're getting both your benzo and your anti-epileptic ready in that time. And then at that 5 minute mark, you just give them both and see what happens. So this is not an effort to eliminate second line agents from your algorithm, but it's just incorporate them earlier. Give them 10 minutes to see if they work. And if the seizure doesn't break, you've crossed the 25 minute mark. So you're still kind of, I wouldn't call it a safe time frame, but you're getting there earlier with propofol or ketamine. So given that we're only focusing on this journal article, I'm not going to go into what the literature is surrounding propofol and ketamine for breaking status epilepticus. But the general conclusion that we drew from this study is that, look, it's a well-structured, informative study. And I think on top of giving us information that all of these second line agents are the same, it helps us to confront the fact that our approach to first, second, and third line management of status epilepticus should be re-examined with future directions of maybe giving benzos and anti-epileptics at the same time, maybe incorporating propofol or ketamine sooner. And so with that, I'll close it off. We are at 10:21, so we're back kind of on track. So are there any comments from anyone who has experience dealing with status more than me? Because I really haven't dealt with it much.
Thanks, Jake, though. I thought that was a well thought analysis and putting the study in perspective, which is really interesting. Oh, there's a comment from Dr. Ryder.
Yeah, it's with propofol, like again, when I was at the neuro, there were quite a few of the intensivists there who incorporate propofol early, like quite early, and not RS8 doses. They sometimes go 0.3 milligrams per kilo that they say can be quite successful. They said that they don't even need to intubate that much. So
what was early then that you saw? Dr. Ryder mentioned he uses it after 30 minutes. What were the neurointensivists doing?
I hadn't witnessed it, but they said if they saw someone in status that wasn't responding to benzos, they would just go to propofol immediately. Now they're in a neuro ICU, so it's a bit different. Like they have access to these beds, but a few of them said that they still didn't actually have to intubate that frequently. Again, because they're using smaller doses of propofol. And propofol, from what I've been reading, is not well studied yet for status epilepticus, even though intubation is sort of the ultimate treatment for someone who remains in status. So, yeah.
Great. Is there anybody else from the chat would like to comment on the study? If not, then there's a, go ahead, Dr. Dora.
Yeah, my only comment is that once you decide to intubate them and paralyze them, you now have got a patient paralyzed that can still be seizing and you don't know.
Yeah, and I know that one of the critical care FOMED resources said that that's a very touchy issue in terms of maybe attempting, even though these are going to be difficult airways, to only use propofol or ketamine for the intubation itself, which already is very difficult. So they do recommend succinylcholine to at least have a shorter duration of action. But again, this is new territory, I believe. Yeah. All right.
Okay, great.
I think...
So yeah, I think that's about it. If